I guess y'all heard it. She knows. And also, I did a little something the other day. I ordered an actual background to replace this one to come in, so you don't have a twin size comforter sitting behind me when you see this. I may actually get to use a green screen or something like that. I ordered all that, but also, yeah, I'll be fancy. That's right. I ordered some blinds, some 100% blackout blinds, so that I wouldn't have that offending sun behind me. You don't want to see outside. My outside window is not that great. Besides that, and it'll silhouette my face. We can't have that. That's right. It never is. Wow. I'm not trying to make visually appeasing. It's learning. It's conducive to learning. All right. I'll share a screen. All right. Can everybody see the PowerPoint presentation? Fantastic. If I have to re-download this book one more time, I'm going to quit. You shouldn't have to re-download the book. It's going to be the same book. Why would you have to re-download the book? Do we get a hard copy? No, I don't even get a hard copy. You can order the book. That should have been sent out, or it was along with the syllabus. Yeah, you can get a hard copy if you order one. I didn't get one. I asked for one, for an instructor one. I still haven't received it yet. I don't read fine. It wasn't even fine print, Mr. Wade. Mr. Wade, are you a firefighter? Yeah, that makes sense. I get it. All right, moving on. So up next is more abuse and confusion, if you let it be. So everybody knows pathophysiology. If you don't know, you're about to. It's the study of physiology of altered functioning in the presence of disease. Okay. So when the body can no longer maintain homeostasis, diseases result, right? To understand the disease processes, you must first understand the way the disease alters the structure of and function in cells. So, sorry about that. There, it wouldn't click for me for a second, it froze up. Could we get into the patho of COVID? Like what it does? We will as we go. And I definitely can. but we will at some point. All right. So, adaptations in cells and tissues. When exposed to adverse conditions, cells undergo a process called adaptation. It will be pertinent. As long as you're healthy and fresh and wash your hands and everything, you should be fine. So atrophy is a decrease in cell size due to a loss of subcellular components. And then you have hypertrophy. Man, I don't know why I'm gonna get tongue tied today. It's an increase in the size of cells due to synthesis of more subcellular components. And then you'll have hyperplasia, is an increase in the actual number of cells in an organ or a tissue, right? Dysplasia is an alteration of the size, shape, and organization of cells. I feel like my kid's been in here. He's done lowered my chair. Oh, there we go. All right. So, and then lastly, but not leastly, you have metaplasia. So this refers to the reversible cellular adaptation in which one adult cell type is replaced by another. Okay. Metaplasia. All right, so up next, we got disturbances in fluid balance. The human body is composed primarily of water, right? So changes in fluid and electrolyte balance can disrupt homeostasis and can either cause or exacerbate various disease processes. So changes in fluid and electrolyte balance that disrupt homeostasis can either cause or exacerbate various disease processes. I literally just said that. I don't know why my note said it twice. The excessive output or input of fluids can also upset the homeostasis. And then the degree of fluid imbalance required for compromised homeostasis depends on the patient's size, age, and underlying medical condition, just like we talked about. So as in with COVID, things that can actually cause that imbalance or fluid imbalance or compromise homeostasis: size of the patient, age of the patient, and underlying medical conditions. Just like I talked about, if you're at a larger size, you're at more risk. You're at risk for getting these issues because your body's having to work harder constantly because of your size. If you're if you're obese, if you are anorexic, of course your body's working against homeostasis as well, because your body's not prepared for those type of sicknesses or illnesses, or it doesn't have enough nutrients to handle itself. So your body's working overtime to try and keep its homeostasis in an anorexic state. As well as age, as you know, as you get advanced in age, then you're going to have issues with the slowing of that cellular respiration, the things that don't work as well as they used to, or they're a little bit slower than they used to be, or your protections are down, they're worn out, basically. And then underlying medical conditions, which means, again, your body's already working on something, or already has all of these processes in place to fight off these abnormal illnesses. So whenever something else gets introduced, such as COVID, and this is the way my belief has been, and the way my studies have been, is whenever you get COVID, if your body's not used to fighting off diseases, then your body's not going to have such a strong reaction to it. I think COVID causes a stronger reaction to people than what a unknown disease process or what some disease processes like in younger people does. That's why you hear that, some people who don't fight off a lot of diseases that are fairly healthy and what have you, whenever they get hit with COVID, their antibodies and everything else doesn't attack it as aggressively. But whenever somebody has advanced age, size, or underlying condition, their antibodies in their body and their processes for fighting off diseases are already aggressive and already knowledged. So they fight hard when COVID comes in. Something in there triggers it, and your body fights it hard. Because of this, that's how antibodies and those disease fighting processes can actually harm you. Okay. Because it's fighting so hard that it affects the rest of the homeostasis of your body because of the advanced antibodies that are in your body. So like in children aren't used to having those types of illnesses. So the body doesn't fight it as hard. That's why they get the sniffles, they get a little bit of a headache, and then it goes away. Or in a healthy person, they get the sniffles, a little bit of headache, they're down for a couple of days, and it goes away. But then you have people whose bodies fight constantly. Well, what's left is the COVID fighters, right? And then they fight so hard, and everything kind of fights the COVID so hard that it jacks up the homeostasis even more. And when you have that issue, then other things start to happen. And then read, if you ever get a chance to see some of the ICU reports from COVID, read those and talk about how people on vents, how, the peat pressure is the issue. They're having problems with peat pressure. People that are on ECMO. ECMO is something very good to learn about. Look for why ECMO works so well with COVID. What does it do? And when you know that, you'll be able to follow the pathophysiology into what COVID actually is by learning what ECMO does. So we can definitely do that. I could talk about this forever. I like pathophys. Oh, look at that. What do we call that? That picture right there to the right? Well, that's the whole thing. I wished it was just a picture first. It's edema. All right. So edema is the swelling caused by excessive fluid trapped in body tissues. All right. So causes of this include increased capillary hydrostatic pressure. Okay. Allergic reactions or inflammation, venous obstruction, pregnancy, heat stress could all cause that. It's also decreased colloidal osmotic pressure in the capillaries. When we talked about colloids the other day, we hit a little bit on it. So you could probably look back and see that again, crystalloids and colloids and everything else. So you could probably look back on that and kind of get an idea of how that process works. What you also have is a decreased production of plasma proteins in patients with liver disease or severe protein deficiency, increased loss of plasma proteins from kidney diseases or extensive burns. You can have issues then. Obstruction of the lymphatic vessels is another one. So the clinical manifestations of edema may be local or it may be generalized. So in an in-depth physical assessment, that's going to include auscultation of breath sounds. Because what are we listening for? If we're listening for edema, what are we auscultating for? Fluid. That's right. And what do they call that? Does anybody know that? Awesome. Good stuff. So next, you're going to look for evaluation of pedal and sacral edema, and jugular venous distension. Okay. So pedal, where's that edema? And sacral, where's that edema? Or sacral. Okay. Okay. Yeah. I always look for multiple system issues when edema is present. Yes. One of the, and then how do we grade that? How do we grade that edema? By hand. Let's talk about it by hand. What do we call that? Does anybody remember from EMT? Pitting edema. That's right. That is correct. All right. So, and then jugular vein distension. Jugular vein distension. What is that from? What does that cause from? That can cause jugular vein distension. My family has added me to a Facebook messenger group, and now it's all the time. That's CHF. That is another cause. But what specifically causes, not what disease process has the symptom of jugular vein distension? What causes the jugular vein distension? But does it though? It is blood backup. That is right. From which side? From which side of the heart? Okay. And we'll move on from this, but I want everybody to think about that. Okay. This is how we get into the disease processes, knowing what cause. This is the way I want you to think. Don't just think I see jugular vein distension. Oh, this could be a head injury. Jugular vein distension. Oh, it could be CHF, jugular vein distension. It could be this. You're right. It could be all those things, but that's a long list of things. So you take what you are looking at, your jugular vein distension that you're looking at, and you know that what causes jugular vein distension, not what jugular vein distension, what disease processes have that in it. You want to know what causes that jugular vein distension. And from there, you know it's a blood backup. Then you know what side of the heart it comes from. Then from there, you can kind of start making other things. Hey, I got jugular vein distension along with crackles in the chest or upon auscultation, but I hear it in the lower lobes. And then you start thinking of this kind of stuff. Oh, and also this patient has pitting edema. Do you have any reports from your last doctor's visit, or what did your last doctor's visit say? Or do you have, something nearby? Sometimes they keep their folder on them. And if you look in there and you're seeing, hey, they're having ejection fraction difficulties, or their ejection fraction is terrible and everything else, it gets your brain thinking. And then next thing you know, you're like, when you're trying to do your treatments, how do you want to treat that patient? Because they already have edema. So you want to put that patient on fluids. What's going to be a problem with putting that edema patient on fluids? What fluids do we want to look at to push those out? Yeah, you'll drown them. That's right, you'll drown them. But there are types of fluids that you can give. Okay. Well, that's one, but you can't give that. You can't give Lasix. So there's other types of fluids that, what do we call those though? What do we call those fluids? Hypertonic. Awesome. You don't put a question mark. I want you to know it. When people put a question mark, I always think of like the Valley Girl thing. Hypertonic? No, be confident. You know the answer. You definitely know the answer. Because you wouldn't have said it at all if you didn't. So hypertonic, that's why we now know these hypertonic, hypotonic, you know, what type of fluids do that? Are they? You tell me. Ty, that's too easy to even Google. You can Google that. All right. And don't tell me crap like that. All right. The next thing, before I get too far into this, we'll talk about fluids again. But this will get you thinking. This will get you thinking, because now you're going to be like, what does do that? What does take those cells out, and why does it do that? What is it made of that takes that water and displaces out there, or where I can push that out? Another thing, something that you can do. All right, you got a patient with crackles that's got all these issues with them, and that patient is having a hard time breathing because you hear the crackles, what have you. What can you put on that patient so that you can push that out? CPAP. That's right. What does it take to put on a CPAP? What does it take to use CPAP? What's some things that you got to make sure that you have? How much O2? You know O2, but how much O2? A bunch. Yeah. Okay. On a setting of, this is the things you got to know. So automatically, you know that if you got to be running O2 at this rate, then you need to be prepared to take that patient out of that house quickly, right? Because that little bottle you got is only going to last you a short amount of time. So when you first get in the truck to check it off, full bottle, you know, and keep an eye on that. When you first get a check to do that check off in that truck, how much O2 do you have in your truck? It all counts. It all counts. And you got to know that kind of stuff. Yeah, pretty much. Depending on the size portable, it sure does. About 5 minutes. So by the time you put that on there, you need to get that patient to that truck, huh? It only don't last that long. All right, sorry. Moving on. So, and then also you're going to evaluate other vital signs for that. So the definitive treatment depends on the underlying medical conditions. Like we talked about, you're going to find those underlying medical conditions. You're going to ask about those. Okay. You're also going to do your field diagnosis on those as well. Y'all are going to be fantastic AEMTs, non-medical providers. All right. So just what we were talking about, right? So isotonic fluid deficit. Isotonic fluid deficit is a decrease in extracellular fluid with proportionate losses of sodium and water, right? It's the most common form of fluid loss, the most common form. Isotonic fluid excess is a proportionate increase of sodium and water and extracellular fluid. So common causes with this include kidney and heart failure issues, right? Then you have electrolyte imbalances. So sodium regulates fluid balance, total fluid volume, and blood pressure in the human body. It also facilitates muscle contraction and nerve impulse transmission. Okay. hypertonic fluid deficit occurs due to disproportionate loss of sodium during water loss. Hypertonic fluid deficit occurs due to disproportionate loss of sodium during water loss. Okay, so you get into hypernatremia. It's a serum sodium level of 130 or 143 MEQs per liter or higher. Okay, and then you have hyponatremia, is a serum sodium level of 135 MEQs of per liter or less. Okay. The causes of hypernatremia and hyponatremia include excessive sweating and heat or during exercise, gastrointestinal losses through vomiting and diarrhea, and then inappropriate use of IV fluids. Inappropriate use of IV fluids. That sounds like a provider issue, right? But we would never cause issues, huh? But they put it in the book. All right. Next one here. Potassium. So, along with the electrolyte imbalances, potassium being one is critical for many cellular functions. Normal serum level of potassium ranges between 3.5 and 5 MEQs per liter. All right, this is the stuff I like to talk about. Hypokalemia is a decreased serum potassium level, which causes include decreased dietary potassium intake and absorption, or decrease in the shift of potassium into the cells, and then renal potassium loss, as well as extrarenal potassium loss, are all causes for hypokalemia. Hyperkalemia is an elevated serum potassium level, which causes include decreased excretion, and then shifts of potassium from within the cell, and then excessive dietary potassium intake. Excessive dietary potassium intake. I just had a thought. Stick with me. Okay, that's going to be a discussion question. It can cause muscle cramps. That's right. What food do they tell you to eat in order to prevent that? Banana. That's right. Sorry, I have young kids, so if I make references to things that seem childish, then I don't care. Because I do like those movies. Sorry, I was getting into, and I'll show it later. I was looking at hypokalemia, hyperkalemia, and then 12 lead EGs, and I was going to show you, but I got a feeling that we would be running way into it. Yep, spike T waves. Huh? That's right. What else? What we talked about. Spike T waves. So spike T waves, rhabdomyolysis, right? There's a correlation. There is a correlation. All right. So calcium, another electrolyte imbalance. We'll be talking about calcium. So nearly all 98% of the body's calcium is found in the bones and teeth, right? It lends strength and stability to the collagen and ground substance that form the matrix of the skeletal system. Your calcium does. Makes sense, right? It enters the body through the gastrointestinal tract. Calcium does. Normal serum calcium ranges between 8.2 and 10.2 milligrams per DL, right? So when you start looking at levels of different types of electrolytes and fluids and ABGs, we'll start to see trends in there in those numbers. We'll talk about that later on in the course. But just start looking at them some. You'll start to see trends. Hypocalcemia is a decreased serum calcium level, which causes include decreased calcium intake or absorption. You have increased calcium loss, endocrine disorders, and sepsis. I always encourage people to study up on sepsis because it's a killer, first off, but it's avoidable. It's avoidable of being a killer. You can head it off at, if you find it early enough, you can head it off, but you have to recognize it. You have to know how to recognize it. And hospitals, I know, and it's starting to catch on into the ambulance realm or into the ALS realm, the field ALS realm, that starting to catch on a little bit more as to the recognition and the combat of sepsis. All right, up next, you're going to have a hypercalcemia. It's an increased serum calcium level. Some of the causes include increased calcium intake or absorption, endocrine disorders, and neoplasms. So here's an illustration that shows the regulation of blood calcium levels. It's great, right? All right, next one's going to be phosphates. It's primarily an intracellular anion. It's essential to a bunch of human body functions. So hypophosphatemia is a decreased level of serum phosphate. Causes include decreased supply or absorption, excessive loss of phosphate associated with the use of diuretics. What are diuretics? Anybody tell me that? Yep. That's correct. Removes fluids. There you go. Yeah, a bunch of nursing home patients do end up with sepsis. Do you know why? UTIs. Yep. That's why we have to look at what? That's as if you're in a nursing home, I's and O's, right? Pay attention to those I's and O's. intakes and outputs. Pee. How much they're peeing or not peeing with how much fluid they're intaking. Other things that are caused the infections, like from bed sores, decubitus ulcers, things like that, cause issues. So another cause is going to be intracellular shift of phosphorus, electrolyte abnormalities, abnormal loss of nutrients, followed by inadequate replenishment is another cause of that. Hyperphosphatemia is an increased level of serum phosphate. Causes of this include massive loading of phosphate into the extracellular fluid, and then also decreased excretion into the urine. But why is there decreased excretion? Magnesium. Magnesium's important. So 50% of the body's magnesium is stored in the bones, 49% in other body cells, and the remaining 1% in extracellular fluid. The normal range of serum magnesium is 1.3 to 2.1 MEQs per liter. Hypomagnesemia is a decreased level of serum magnesium. Its causes include diminished magnesium absorption or intake, increased renal loss of magnesium, and then miscellaneous causes such as diabetes, respiratory alkalosis, and pregnancy. Remember those. Remember magnesium and diabetes, magnesium and respiratory alkalosis, magnesium and pregnancy. Remember those, because they will come back. This will come back. Hypermagnesemia is increased level of serum magnesium. It's almost always occurs as a result of kidney insufficiency. If you look in your book at table 8-2, it summarizes the major electrolytes of the body. Oh my goodness, look at this. Is this acid-base balance again? The fun stuff again? Can we really get this 2 times in 2 weeks? All right. Disturbances of acid-base balance. So pH is a measure of acidity or alkalinity of a solution, right? So the lower the pH, the higher the acidity. The lower the pH, the higher the acidity. Acidosis is an increased extracellular, what do we say H+ ions are? What is H+? Hydrogen ions. There we go. So alkalosis is a decrease in extracellular H+ ions. Disturbances of acid-base balance are associated with disturbances of potassium balance. Oh, here it is. It's the scale. So, respiratory acidosis is related to hypoventilation. So, respiratory acidosis and hypoventilation. So, some of these causes include airway obstruction, cardiac arrest, overdose of a CNS or central nervous system depressant drug, submersion, drowning, respiratory arrest, pulmonary edema, closed head injury, chest trauma, so on and so forth. Okay. So how do we combat that? How are we going to combat that acidosis? Yes, you do. You can give bicarb. You get oxygen in there. There has to be a buffer, right? Remember that buffer? We have to make that acidotic state lean more into the alkaline state, right? So signs and symptoms of respiratory acidosis are going to include systemic or cerebral vasodilation, or both, headache or lightheadedness, warm flushed skin, CNS depression or central nervous system depression, bradypnea, which is slow respiratory rate, right? And nausea and vomiting. So respiratory alkalosis is associated with conditions that result in hyperventilation. Respiratory alkalosis, hyperventilation. Okay. The level of circulating carbonic acid is reduced. Hyperventilation accompanied by carpopedal spasms is the classic sign of respiratory alkalosis. What are carpopedal spasms? Carpopedal spasms. Carpopedal spasms. Come on, Ty. Let me hear it. Okay. Carpopedal spasms. Yes. Yeah. Yep. Like cramping or tingling in the hands and feet when you start to notice it. Okay. Now everybody should be getting a little familiar with that. So if you ever heard or had this happen before, hyperventilation, if you ever hyperventilated before, or you talk to anybody that's going through hyperventilation, what's one thing they say? I can't feel my fingers. I have tingling in my fingers or in my hands or in my feet. They say that a lot. That's a carpopedal spasm. Okay. Causes of hyperventilation, respiratory alkalosis are going to include drug overdoses, fever, overzealous bag valve masking. Interesting. Overzealous bag mask ventilation. Okay. So signs and symptoms are going to include Signs and symptoms are going to include diminished level of consciousness, lightheadedness, carpal spasms, paresthesis of the lips and face, so tingling, can't feel the lips and face, chest tightness, confusion, vertigo, blurred vision, nausea and vomiting, all things like that. And then you have up next, getting away from the respiratories, up next you're going to have metabolic acidosis. Okay, so metabolic acidosis it's any acidosis unrelated to the respiratory system is considered metabolic. And causes of metabolic acidosis are going to be lactic acidosis, ketoacidosis. Anybody ever done the keto diet? Aspirin overdose, excessive alcohol ingestion, so alcoholic ketoacidosis, gastrointestinal losses, carbon monoxide poisoning was another one. Signs and symptoms are going to be vasodilation. This is of acidosis, metabolic acidosis. It's going to be vasodilation, central nervous system, depression, headaches, warm flushed skin, tachypnea or elevated heart rate, right? Nausea and vomiting, cardiac dysrhythmias. Now, metabolic alkalosis occurs due to an excessive loss of acid. Rarely an acute condition, but common among chronically ill patients. Causes include excessive vomiting, excessive water intake, nasogastric suctioning, lots of it. Excessive intake of alkaline substances also cause it. Signs and symptoms are going to be confusion, muscle tremors, cramps, bradypnea, and then hypotension. All right, now we're going to talk about cellular injury. So various processes may cause cellular injury. We'll talk about hypoxia, so lack of oxygen, ischemia, which is lack of blood supply. You have chemical injuries, infectious injuries, immunologic or hypersensitivity injury, physical damage, which is a mechanical injury, or inflammatory injuries. Now let's break them down. So manifestations of cellular injury occur at the microscope or structural and functional levels. Microscopic. So common microscopic abnormalities are going to include cell swelling, rupture of cell membranes or nuclear membranes, breakdown of nuclear material such as chromosomes. Functional disturbances may include inefficient oxygen utilization, intracellular acidosis, toxic waste accumulation, derangement of nutrient metabolisms or metabolization, sorry. And then dysfunction in one system inevitably is going to affect the function of other systems. Cellular injury can be repaired up to a point with a proper treatment. So dysfunction in one system inevitably affects function of other systems. Now, what do we call that? Whenever multiple systems start to function incorrectly, what do we call that? You remember that from EMT? Multi-organ failure. Yep. But there, we have a short term for it as well. Something that we use that may help it may click in everybody. What do we call that? MODS. That's right. Which is what? MODS is what? You can call it multi-organ failure, MOFs, but I think the more common, I'm sorry, Hannah, you are correct. MOF is a abbreviation for it, but MODS is some, I think that's more widely used that I've seen, which is multi-organ dysfunction syndrome. And yep. And so whenever you have body systems that start to just kind of fail one after the other, then we get into MODS. All right, so hypoxic injury. Hypoxic injury is common and often deadly. It's a cause of cellular injury, often deadly. May result from decreased amounts of oxygen in the air, loss of hemoglobin function, decreased number of red blood cells, disease of the respiratory or cardiovascular system, loss of cytochromes, cells that are hypoxic for more than a few seconds produce mediators, which can lead to more cell damage. Free radicals are the earliest and most dangerous mediators produced by cells. You get WD-40 for this chair. So chemical injury, a variety of chemicals may injure and ultimately destroy cells. Common poisons include cyanide and pesticides. Cyanide induces cell hypoxia, and then pesticides prevent proper transmission of nerve impulses by blocking the enzyme acetylcholinesterase. One of those terms. So long-term ingestion of lead leads to brain injury and neurologic dysfunction. You know, did you eat paint as a kid? Did you eat paint chips as a kid? I know you've probably heard that before. Somebody has. And then long-term ingestion of lead leads to brain injury and neurologic dysfunction. Carbon monoxide prevents adequate oxygenation of tissues. And then higher doses of ethanol produces severe central nervous depression and hypoventilation. So cyanide induces cell hypoxia. All right, so cyanide. What is something that when we talk about that we may go to as far as ambulance, if we're on an ambulance, and there's always a possibility of this anytime you get called to what type of calls for standby. So you are called as a medic to go to a standby to a type of call. Okay. Some of the things that you should start talking about or thinking about is cyanide. What is that? That's right, Ty, fire. So anytime you have to go to a standby for a fire, then you should automatically be thinking in your head some of the things that could happen. All right. cyanide poisoning because smoke, because of all the byproducts of combustion and everything of the combustion in different types of houses or different types of furniture and everything else. So lead-based paint. Well, mostly you're looking at the cyanide. Is looking at that, that it's smoke inhalation, things like that. How are we going to combat that? Okay. So you got to start thinking about that in your head. How are we going to combat this? Because it's not just burns. It's not just the fact that they're going to be dehydrated, but there's things that when they come out with that smoke inhalation, patients that come out with smoke inhalation, how can we combat that? Okay. Alrighty. So infectious injuries occur as a result of invasion of bacteria, fungi, or viruses. So virulence measures the disease-causing ability of a microorganism. We got depression. A depressed immune system is less capable of fighting off microorganisms, much like we talked about with COVID, right? We talked about that. A depressed immune system, if it's already depressed by other underlying medical issues, then it's going to be less capable of fighting it off. It's going to divert. There's going to be a severe diversion in that fight. Okay. White blood cells release endogenous pyrogens. What is an endogenous pyrogen? Do y'all remember that? I know y'all know it. I'm starting to reference things from the past, and I'm not supposed to do that, am I? Now you have to think about the last chapter. All right, somebody find it and then get back to me on it. What an endogenous pyrogen is and does. Okay, and I will be looking in my chat right here. Let's try somebody else other than the few that answer quite a bit. Somebody hit me up. And Rob, you don't hit me up. I just saw that you were in here. So viruses take over the metabolic processes of the host cell and use the cell to replicate. A virus consists of nucleic acid core of ribonucleic acid RNA or deoxyribonucleic acid. Okay. We talk about disease process and we talk about the fighting of viruses and disease process. There's other things that we can talk about too, like mRNA. So if you remember, if y'all have ever read mRNA or messenger ribonucleic acid, how does mRNA speak into what we've been seeing lately for the combat of COVID? mRNA, where does that come into play when we're talking about COVID? Something lately been hearing a lot about. Vaccine. That's right. So the vaccine uses mRNA, right? And the mRNA does what? The mRNA in the vaccines does what? Speculatively. It tricks your body. More importantly, it teaches certain cells to do what? It doesn't trick, it teaches. Yep. Endogenous pyrogen is capable of inducing fever. So endogenous pyrogen, right? Fire, increased temperature. That's right. Makes a protein to trigger immune response. It does. It teaches it to make the protein to trigger an immune response to fight off COVID. So it's not like, so rather than introducing a deadened form of a virus or a deadened form of an illness, such as past vaccines, it introduces mRNA, which is not a deadened form of anything. It's mRNA, which teaches the body to combat these certain types of proteins, or makes a protein that triggers an immune response, or teaches the body to fight off this virus using mRNA, not a deadened form. So it's supposed to be safer because of this. Supposed to be. That's as far as we'll get into that. The theory. All right. So many bacteria have capsule that protects them from phagocytes. So that's great. We already went through all that, right? We talked about what that protection is. All right. So immunologic and inflammatory injuries. Immunologic or inflammatory injury, right? That's what we're talking about here. Sorry. Inflammation is a protective response occurring in the presence of cellular injury. Inflammatory response can be triggered by a physical, chemical, or microbiologic agent. Signs of inflammation are heat, redness, tenderness, swelling, and pain, right? And then if the inflammatory process is severe, systemic effects become evident. So a person feels ill and the body temperature is elevated. The bone marrow accelerates its production of leukocytes. So the number of leukocytes circulating in the bloodstream increases, which what we would call leukocytosis, right? And then outcome of an inflammation response depends on the amount of tissue damage there is that's going to cause that. So the body's working extra hard, right? The body's trying to fight off whatever's going on. So it's going to cause all these inflammatory responses within the body. All right. So the bone marrow accelerates its production of leukocytes. So the number of leukocytes circulating in the bloodstream increases, causing the leukocytosis we talked about in the last slide. So here's some of the process. What we talked about there. So injurious genetic factors, an abnormal gene may develop by mutation of the gene during meiosis, and then by heredity or as a result of other causes later in life. So genetic factors that may damage cells include chromosomal disorders, premature development of arthrosclerosis, and sometimes obesity. What is arthrosclerosis? Can anybody tell me that? Arthrosclerosis. Come on, break it down from chapter 5. Arthrosclerosis. I just had a discussion about this the other day. I don't remember why. Torrance, let's hear from you. What is arthro? Okay. All right. So hardening of the arteries. That's right. Arthrosclerosis. I'm going to start having to call people out, getting some answers. That's okay. All right. So injurious nutritional imbalances, it's going to include obesity, malnutrition, vitamin excess or deficiency, and mineral excess or deficiency. So something with the body, with the body itself is everybody likes to take vitamins, right? Everybody does like to take vitamins when they're young. So when you take vitamins or you add things that your body already makes, and you necessarily don't need these things that your body already makes, but you're adding them anyway, what does the body do in a response to that? So let's use melatonin, for example. If you get to a state where you're finding yourself not able to sleep on a regular basis, and so you start taking melatonin on a regular basis, what does your body do with the melatonin that it currently produces? Anybody tell me that? It stores it. It stops producing it. That's right. It lessens the production of it, which makes you dependent on that vitamin. At that point, you'll have to keep taking the melatonin to sleep. So it won't store it. It will lessen the production of it. It's kind of like something that you see a lot in people if they use Afrin or nasal, I forget what you call it, nasal medication, and they use it all the time. They use it all the time because they were having issues with their nasal passages not opening and wouldn't open naturally, so they use Afrin, right? Well, then they become addicted to it because now their body needs that Afrin in order to keep their nasal passages open. All right. So they're addicted to it. Their body becomes accustomed to it. It's the same with anything that you take into your body. Your body becomes accustomed to it, just like alcohol. Your body becomes accustomed to the chemicals in alcohol. So if you were to just stop taking it or stop using alcohol after you've been using it for an exorbitant amount of time, you can go into withdrawals, things like that, because your body is used to having it. So you have to be careful. Should adults take vitamins only under a doctor's orders? So I think not necessarily. You can take, yes, your body can do the same with caffeine as well. Your body will get to where it needs it. And that's why you find yourself, you don't drink a coffee in the morning, you'll have a headache or you'll just feel like crap. That's where that comes from, caffeine dependency. Luckily, you can always break off from those. So should a doctor take vitamins only under a doctor's orders? I think that you should definitely speak to a doctor before you start getting into a supplemental regimen. And it's not, like I say, when I talk about supplements, I'm talking about workout supplements. I'm talking about herbal supplements, anything that you're going to take into your body to replace, add to, or replace or add to your body, because you affect the homeostasis of your body, what your body's normal functioning limit is when you start taking those. And that goes for all patients. So yes, I do believe that you should consult with your doctor before you take any type of vitamin supplements or anything like that. But think about that when you have those patients. That's why when you're doing that sample, because sample's so easy, right? Everybody gets that. And you get to that medications, don't just say, what type of medications do you take? What type of supplements do you take as well? because that may help you on your differential diagnosis. Because somebody that takes B12 all the time, in their normal state, they would be drugged down and tired and out of it. But if they're taking B12 and they don't announce that they take B12, then they're like, well, my energy level is just fine. But that person's sick. Why they have so much energy, or why is their heart rate at this point, or why is it, there's something else that could be helping with that, helping combat some of these symptoms of illness that you're there to check out. So that's why it's important to know what type of supplements, medications, anything, herbal supplements, vitamins, anything like that. They need to tell you. Yep, testosterone. And that's not just testosterone supplements. A lot of times they get people, men that have low T. So men that have low T get testosterone supplements. It's not just for workout or anything else. It can be for other conditions that they may have. And you'll get patients, and that low T is a big deal too, because it causes other types of disease processes in the body. All right. Yes, absolutely. Go for it.
All right. Sorry, I don't know if y'all can hear me. Yeah, no, it's just one of the calls that I ran recently actually was at a gym. The guy had been feeling kind of down for a while, and I've come to find out through sample history and everything, like you're saying, he was juicing himself up on testosterone. I know you could tell when you saw him, but one of the things about it was that he had come off of it. And when you do that, especially, some guys have low T on their own, but if you're giving yourself shots all the time, just like you were saying, your body starts to, if it's getting it, it's not going to waste energy trying to produce it. So he spent all this time giving himself shots, and then he comes off of it. His body has pretty much wiped its hands of making its own testosterone, so that dipped. And with that hormone imbalance, now that person was having to deal with weight gain. He got sick more often, just general things. Like a lot of our ability to resist things comes from our testosterone as guys. So he was getting sicker, he was getting depressed, and then he got sick, and he I don't even know what it was, but it was something that he would normally have been able to resist. He didn't realize it, went to the gym, was trying to juice up with it, not juice up, but like take his pre-workout and everything. And when we got there, he was having heart palpitations and flutters and everything. And it was a combination of what he had taken right then, which really wasn't normally that bad. It was the same pre-workout that I've taken before. But coupling that with the way he had thrown his hormones out of balance really, really played into it. So, when you're talking about your meds, for example, don't just ask them what they take. Ask them when they last took it. If it's something they're supposed to take every day, then you want to know if they did that. If it's something that they're trying to do as a supplement, it's not necessarily just, are you taking it? It's, did you stop? And how long ago did you stop? Because your body's going to rebound usually when you come off of something. That's all.
Awesome. And after that, we're going to have to take a 10-minute break to process that. Now we're running on over an hour. So one thing, I already ate supper, so my timer function is going to be off. But we will adjust around that. All right, so what I'm going to do is I'm going to go ahead and start this 10 minutes up as soon as this little video quits playing on here. And then we're going to go. Hold on, I'm sharing it now. All right, can everybody see that? I'll even start it back. All right, so 10 minutes. I'll see you guys in 10 minutes. Thank y'all very much. All right, we're back. We're back. Not starting it over. I see Genevieve. It's in the name, Genevieve. All right. So we got everybody here. Nobody's sleeping. Good to go. All right, so back into it. Can everybody see it? Okay, great. Injurious physical agents or conditions. So physical agents such as cold and radiation may cause cell injury. Yeah. And then like things like burns, frostbite, radiation sickness, things like that. And then you have a degree of cell injury is determined by strength of the agent and length of the exposure. So like when we talked about like radiation. So time distance shielding is the best protection from radiation. But if you are subjected to radiation, then the strength of it and then the length of exposure is going to make a big difference into those cell injuries. So that's why your X-ray technicians or CT technicians have to wear. Does anybody know what they're called? Anybody remember what they're called? Dosimeters. Hold on right quick. What is the device that you have to wear at work in order to measure dosimetry?
Dosimeter.
It is called the dosimeter, a little tab dosimeter, or what do they call it?
Dosimeter.
Okay.
There's different kinds.
Okay. That's all I needed.
Okay.
Thank you, sweetheart. Now she feels wanted. She feels needed. So yes, dosimeters or dosimeters, whatever you want to call them. It's part of the medical analysis or continuing medical analysis for employees. After you reach a certain amount on that dosimeter that she wears on her badge, after she reaches a certain amount, because it gets tested ever so often, then they can even make it to where you can't come to work anymore. And same thing if you're pregnant, there's a certain amount, and that you can only get to there before they'll make it to where you can't come into work anymore because you've been exposed too much. If you ever get an opportunity when we talk about radiation, there's several movies that are really good for it. One recent one that just came out is about Marie Curie, and it's called The Something Girls. I'll think of it right quick. My wife will know, she liked it. But it gets a little into it. The whole movie is about the length of exposure and the strength that these girls were getting. But it all ties back to Marie Curie and and her husband, the invention of, or the founding of radiation. All right. Yes, Ralph. Lead aprons. They do wear those. And the neck protection. You got to make sure the neck protection is there. Hear about that all the time. Because they get issued their own. So next, we're going to talk about apoptosis, which apoptosis is normal cell death. It's genetically programmed into the cells as part of a normal development of organogenesis. Organogenesis is immune function and tissue growth. So unlike in the case of cell death from disease processes, proteins and DNA undergo controlled degradation that allows their remnants to be taken up and reused by neighboring cells. So areas that have undergone apoptotic death do not show any evidence of inflammation because it's natural, right? And it's done at a certain rate, all right? That can maintain a certain maintainable rate. And it can be activated prematurely by pathologic factors such as cell injury, and then inhibition of the normal course of apoptosis allows destructive cellular proliferation in that. So if you inhibit the normal course of a natural cell death, it will allow for destructive cellular proliferation. Apoptosis. So next, if we're going to talk about normal cell death, then the next thing we're going to talk about is radium girls. Good one, Leanne. Radium girls. That's about the radium, and then they had the watches and everything. That's what stemmed from Marie Curie's invention was the radium. She found radium, and then from there they had the radium girls, and it talks about all the stuff that was put into radium. It was crazy when you see just how much what they were doing with this radium. Like it was the wonder drug, the wonder everything. Yep. Crazy. All right. So like I said, sorry, I got off subject there. Normal cell death. Now we're going to talk about abnormal cell death. Necrosis is the term for tissue death. And it's the result of morphologic changes that occur following cell death. Okay. Simple necrosis refers to areas of necrosis where gross and microscopic tissues and some of the cells are still recognizable. It may be caused by acute ischemia. What is ischemia? Does anybody remember that? Yep. Well, ischemia being it's more something, not just blood loss, but it's some sort of, it's going to be a lack. No. Yes, it does have to do with that, but there is not, it's an abnormal blood movement, right? An ischemia. You can't, the blood isn't moving into the areas is that it's supposed to, or that it can normally, or that it's supposed to normally. Okay. And in which so ischemia is is an injury. Ischemic, it's an injury, like a blood flow injury. So acute toxicity or direct physical injury may cause simple necrosis. So derived necrosis includes cessation necrosis, dry gangrene, fat necrosis, and liquefaction or liquefaction necrosis, which is nasty. Liquefaction necrosis. So is dry gangrene also. Gangrene's pretty bad necrosis in itself, if you've ever been around it, smelled it, or anything like that. Gangrene. So you talk about gangrene. It's gangrene, Genevieve. Genevieve, did you ever watch Cupcake and Dino? You're gonna need to. I'm telling you. All right. So hyperperfusion. Perfusion is the delivery of oxygen and nutrients, removal of waste by the circulatory system. Adequate circulation depends on a pumping heart, intact vascular system, and appropriate amount of oxygen carrying blood. What skill do we have that could cause necrosis? Or is this what we're doing now? You asking the questions now? You should know this. We just talked about it. It was one of your discussions. That's right. It was in your last discussion. Awesome, Leanne. D50. More so into what? What can you do? What can you do that could possibly cause that? Putting D50 straight into a muscle, right? Would not be good. Hypoperfusion occurs when the level of tissue perfusion decreases below normal. Hypoperfusion. All right. In response to hypoperfusion, the body releases catecholamines, so epinephrine and norepinephrine, which produce increased strength of cardiac contraction, increased pulse rate, vasoconstriction, and increased systemic vascular resistance. All right. As hypoperfusion persists, myocardial stress increases. Myocardial. So myo being what? Myo means muscle, cardial, heart. So heart muscle stress. Okay. Shock is an abnormal state associated with inadequate oxygen and nutrient delivery to the metabolic apparatus of the cell. So this is going to result in impairment of cellular metabolism and inadequate perfusion of vital organs, right? If the body's compensatory mechanisms are sufficient to stabilize the patient's condition, the shock is called compensated shock. So if the body's compensatory mechanisms are sufficient to stabilize the patient, so if you can stabilize, if your body can self-stabilize, then it's called compensated shock, right? Because it can compensate for the mess up. If hypoperfusion overwhelms a normal compensatory mechanism and the patient's condition progressively deteriorates, it is what we call decompensated shock or hypotensive shock. All right, you start getting into decompensated shock, then you're going to have issues, right? And you're going to have to work. That's when it's time to work. So types of shock. Shock can occur as a result of inadequacy of the central circulation or the peripheral circulation. Central shock, cardiogenic shock, occurs when the heart cannot circulate enough blood to maintain adequate peripheral oxygen delivery. Okay, cardiogenic shock. And then the most common cause of cardiogenic shock is myocardial infarction. Okay. Obstructive shock occurs when blood flow becomes blocked in the heart or great vessels. So what are some forms of obstructive shock? I know everybody knows what cardiogenic shock is. Obstructive shock is a little different. What are some forms of obstructive shock? Let's hear it from some people that I don't get to talk to very often, or I don't get to see very often. Stroke being one of them. Okay. What types of injuries may cause obstructive shock? DVT, break it down. Not everybody may know. Okay. How does deep vein thrombosis cause obstructive shock? Okay. Yep. And where at? And once it goes into the lungs, what is that called? That's right. All right. So all obstructive shock, blood can't get where it needs to go. So a pulmonary embolism is one of the conditions that may cause an interruption of blood flow, right? So some of these conditions can cause a buildup of air or fluid in the chest cavity, can also lead to obstructive shock. So things like pneumothorax or hemothorax or cardiac tamponade can also cause obstructive shock as well. Obstruction, right? If you have, and then also, we won't get into that. Let's pause off on that for a little bit before we get into that. We don't want to get any more confusing than we have to get, right? Cardiac tamponade. Holy cow. So these photos, which are in your book, also figure 8-9. So it shows cardiac tamponade following a myocardial rupture. Okay. The left is a distended pericardial sac on the left. Okay. The right pericardial sac is opened, showing clotted blood around the heart. And that's what all that is, which compensated the heart and prevented the filling of the right ventricle in diastole. See all the clotted blood? More importantly, when it gets in that pericardial sac, that blood filled up that pericardial sac and starts squeezing on the heart. And the heart could no longer, since the pericardial sac usually does this, well, now that it's filling up, it can't do that. And when it starts to do that, and when it starts to squeeze on that heart, the heart's having to work extra hard. And sooner or later, it's going to fail. Hold on right quick. I got retreat. Okay. Rob, there's a fantastic app that I found the other day that's great for the iPad and great for, touch iPads and everything. And you can actually get into some of these systems, and it's very good for pathophysiology and showing how it is. We can talk about it later. It's fantastic. I thought about just buying it on my own and using it.
What's the name of it? I'll go ahead and start looking into it.
I don't know. Let me look. It was something
that we can hit it up.
Yeah, we'll find it
later on. Sounds good.
So this illustration here, it shows the sites of thoracic aortic dissection. Okay, and then A A, which is this side, right? It's a tear in the ascending aorta. Causes proximal and distal dissection. And then B is a tear in the descending aorta that may cause extensive distal dissection. And you see here, this all fills up with blood. So some of the other things that can cause that dissection as well is, let's say you have a patient that, because everything's attached, right, to keep it still. This little bit of tissue here is attached to something that keeps it in place. So if you have somebody that has a car wreck and they hit, they hit that wall, bam, then everything in that body from this side is now transfer of energy through here. So a lot of times what you'll have is that descending aorta. A lot of times it will separate. It'll separate from the back, all right? From the tissue where it's placed at, it'll separate from close to where the spinal column's at, where as it goes down, it'll separate that tissue out and you'll have a dissection in the descending aorta. And a lot of times, patients talk about their back. It feels like it's on fire. They have back pains, it's burning, and it may be because of a dissection. So some things to look at, some things to think about. It also happens too in illnesses and other types of medical type injuries, is that if they start talking about burning pains in their back or in between their shoulder blades or anything like that, then you should be alert to that. There is a whole lot you can do. There's a medication that we can give those patients. It's called diesel. And for heavy bleeding, TXA. So peripheral shock, it'll be battery sooner or later. Peripheral shock, in hypovolemic shock, the circulating blood volume is insufficient to deliver adequate oxygen and nutrients to the body, okay? There are two types of hypovolemic shock. There's exogenous and endogenous hypovolemic shock. Distributive shock occurs when there is widespread dilation of the resistance vessels, the capacitance vessels, or both. So distributive shock, what is one of the things that distributive shock is more common for distributive shock? The widespread dilation of the resistance vessels. What do you think that would be attributed to most commonly? What do we usually see? Anaphylaxis, anaphylactic shock, maybe, things like that. Because what does it do? Widespread dilation of the resistance vessels. Is everybody sleepy? Don't be sleepy. Anaphylactic shock occurs when histamine and other vasodilator proteins are released on exposure to an allergen. Okay. Don't just take anaphylactic shock and think of it as how you're thinking of it now. When you're thinking of anaphylactic shock, this is what it does. Those vessels are gonna blow up. You're looking at these type of issues, these type of signs and symptoms, blah, blah. Know what it does. Know how the histamines work. Know how the histamines work and how an antihistamine works, or how does that Benadryl work whenever you give that patient that, or whatever you're giving that patient to reduce that injury. We talked about this. Septic shock occurs as a result of widespread infection. We talked about sepsis, right? And then neurogenic shock usually results from a spinal cord injury. So we'll talk about why it does that when we start getting into spinal cord injuries, why it causes neurogenic shock. What is neurogenic shock? These are the chapters here that give you the why behind the what. And in order to understand the what, you need to know why. And in order to be able to talk about it intelligently, you need to know the why behind the what. What type of injury is it? Well, this is why you have this type of injury. So this is where this is what separates you from being a cookbook medic and then an actual critical thinking medic, is these first chapters or this first module. All right. So this illustration here, it shows that how the damage of the spinal cord can cause substantial injury to the part of the nervous system that controls the size and muscle tone of blood vessels. If the smooth muscle in the blood vessels cut off from its impulses to contract, then the vessels dilate really widely. Increasing the size and capacity of the vascular system, the blood in the body can no longer fill the enlarged vessels, which results in inadequate perfusion and neurogenic shock at that point. So management of that shock. Most types of shock are characterized by reduced cardiac output, circulatory insufficiency, and rapid heartbeat. So we have to increase cardiac output somehow. We have to restore circulatory insufficiency, and then rapid heartbeat. Now, notice that it says rapid heartbeat. And it doesn't necessarily mean that it's getting enough blood through the system, right? So shock diagnosis, or I'm sorry, I got ahead of myself. Now, to determine the presence or the absence of shock, we evaluate the presence and volume of peripheral pulses, usually, right? What is peripheral pulses? What are our peripheral pulses? That's right. Doing radial pulses. That's a good peripheral pulse. There are others. There are others as well. Peripherals, in the peripherals. So not just wrist, because you may not always be able to get a good one on wrist. Yep. And the feet, pedal. What do we call those? Pedal pulses, right? And in a pedal pulse, when you find a pedal pulse, what do we do? You mark it. Mark it. You may not find it again. So, so some of the things we're looking for is prolonged capillary refill times indicate shock, and then modeling, pallor, peripheral or central cyanosis, and delayed cap refill. It may signal the presence of shock. All of them may signal the presence of shock. If I can feel a radial pulse, anybody remember this? If I can feel a radial pulse, what should my systolic pressure be? If I can feel a radial pulse, at least what? $80 to $90. $80 to $90. That's right. All right, so we touched on this a little while ago, did we not? Multiple organ dysfunction syndrome, or MODS. It's a progressive condition that occurs in some critically ill patients, characterized by the concurrent failure of two or more organs or organ systems that were initially unharmed. Respiratory, hepatic, renal, hematologic, neurologic, and cardiovascular systems are surveyed in diagnosing MODS. Overall mortality rate varies widely depending on the underlying etiology, and ensuing diagnosis and treatment is going to be a big factor. MODS occurs when injury or infection triggers a massive systemic immune, inflammatory, and coagulation response accompanied by the release of toxins. So we talked about that, right? We talked about toxins and the release of the blood. Some of those toxins being like myoglobin. We talked about that before. Primary MODS is a direct result of an insult such as pulmonary contusion. And secondary MODS is a slower, more progressive organ dysfunction. So continuing with the body's self-defense mechanisms, immune system includes all structures and processes associated with the body's defense against foreign substances. Several anatomic barriers decrease the chances of foreign substances invading the body. Examples of this are the skin and hairs in the upper and lower respiratory tracts, and acid in the stomach are all supposed to help decrease the chances. So immune response. The body's defense reaction to any foreign substance is an immune response. So directed against invading, it's directed against invading microbes, which is bacteria or viruses, foreign bodies, and abnormal cell growth. Okay. The innate response starts first, and then it's reinforced by the more specific acquired response. So components of the cell wall activate the complement system, and then chemotaxins, which we talked about in the last chapter, or last chapter, attract leukocytes from the circulation to help fight the infection. What are leukocytes? Leukocytes. Leuko meaning what? White blood cells. Awesome. Awesome. So chemotaxins attract white blood cells from the circulation to help fight the infection. Complement cascade ends with the formation of set proteins called the membrane attack complex. So types of immune system cells include basophil, eosinophil, neutrophil, monocytes, lymphocytes, macrophages, mast cells, plasma cells, B cells, which are like your B lymphocytes, and then helper B cells. Some others are going to be your memory B cells, T cells, which is your T lymphocytes, and then the killer T cell. There's a lot. There's a lot in there. So natural or native immunity is a non-specific cellular and humoral or antibody. Humoral. It's sorry, I messed that up. It's a humoral response that operates as a first line of defense against pathogens. With acquired immunity, the immune system will never fail to recognize the same stimulant when it is subsequently encountered. What does that sound familiar as? Acquired immunity. Like as in vaccines, yes. But a good one, a good example of it though is chicken pox. So like chicken pox, you get it one time and then you have, yep, that's good. And then after that, you don't get it again, right? Or rarely you don't get it again. You have an acquired immunity for a certain amount of time with COVID. So what is it? They're saying 3 months. You have an acquired immunity, but then it starts to wear. Okay. So passively acquired immunity is the receipt of preformed antibodies to fight or prevent infection. So passively acquired immunity is the receipt of preformed antibodies. The primary or initial immune response takes place during the first exposure to an antigen. An antibody binds a specific antigen. And an immunogen is an antigen capable of generating an immune response. An immunogen is an antigen capable of generating an immune response. A hapten can be combined with an antigen to initiate a specific antibody response on its own at a later time. So a hapten. So it's not hapten right now, right? Not hapten right now. So it can, because it's got to combine, it just happens to combine with an antigen to initiate a specific antibody response on its own at a later time. And in humoral immunity, B cell lymphocytes produce antibodies called immunoglobulins, okay, or immunoglobulins. B cells are born in the bone marrow, B cells, bone marrow, and must be first activated to produce antibodies. The antibodies secreted by B cells are called immunoglobulins, like we just talked about. The antibodies secreted by B cells made in bone marrow are called immunoglobulins. There's an illustration. That helps hammer it in, right? The illustration there. Clear mud. That's right. Wide open like a lock gate.¬ This illustration is also in your book. It's a figure 8-12. It's going to show, it shows how antibodies work. YouTube's good. There's a nurse that nurse that was showing us, or that I showed that video up before. She makes a lot of videos about this, and she's fantastic. She really knows how to break it down, and she talks a lot less than I do. She gets straight to the point. So antibodies make antigens more visible to the immune system in 3 different ways. And antibodies act as opsonins, and in opsonization, an antibody coats an antigen to facilitate its recognition by immune cells. So it's like the reflector, or the flashing light attached to it. It's now beaming. Okay. Antibodies will cause antigens to clump up, and then antibodies bind to and activate some toxins produced by bacteria. Cell-mediated immunity is characterized by the formation of a population of lymphocytes that can destroy foreign material. So cell-mediated immunity. It's the formation of a population of lymphocytes, because it's cell-mediated, right, that can destroy foreign material. So some of these subgroups of T cells, as you can see here on the slide. Sorry, if I point over here, that means I'm looking at my slides on the other screen. So going to be your killer T cells, your helper T cells, your suppressor T cells, memory T cells, and then lymphokine or lymphokin producing cells. So here's another illustration, figure 8-13. Shows the B cell activation. Immunocompetent B cells that are stimulated by the presence of antigen and producing an intermediate cell, the lymphoblast. Lymphoblasts. Okay. The lymphoblasts divide, as you can see here, divide, producing plasma cells. Okay, they're antibody producing plasma cells, your memory B cell, right? And as here, some of your memory B cell. Memory B cells respond to subsequent antigen encroachment, your antigen. So the memory B cells encounters the antigen. And then this induces a secondary response, right? When it produces that secondary response, then you have, oh, where does this look familiar? So then it creates antibody producing plasma cells. And then from there, as in a cycle does, an additional B cell forms, so on and so forth. Back to it. So this one shows the interaction of cell-mediated and humoral immunity. A macrophage or a macrophage presents processed antigen fragments. Okay. And it presents it to the T lymphocytes. Processed antigen to the T lymphocytes. The B lymphocyte processes the intact antigen, so the whole intact antigen, and produced on its cell membrane. The T lymphocyte, which has responded to the same antigen, stimulates the B lymphocyte to proliferate and mature into plasma cells. And then that makes antibodies. That one will make you go to sleep if you're sitting there doing that. Learning about that. All right, and here's another illustration. All right, we're going to take another 10-minute break right quick before we jump off into inflammatory response. All right, so let me pull up my handy dandy 10-minute timer here. Does anybody have any questions before we go on this break? Oakley dokley. Well, let's rip and roar then. So get you some coffee, get you some drink, whatever you need. Eat a Snickers. We'll be back. All right, and we're back. Everybody make it back. Great, fat boy's got to eat. So again, but it's healthy. It's blueberries. Hola. All right. Yeah. All right. So up next, inflammatory response. The inflammatory reaction and immune response are independent processes that occur simultaneously. Most common causes of inflammation are infection and injury, right? So acute inflammatory response involves vascular and cellular components. During inflammation, mast cells degranulate and release a variety of substances. After degranulation, mast cells release vasoactive amines, okay? Histamine and serotonin increase vascular permeability, the ability to move through the vascular system, right? Or move all the way through the vessels and cause dilation, and also can cause bronchoconstriction and nausea and vomiting. All right. Mast cells also synthesize leukotrienes and prostaglandins. Different plasma protein systems are complement system, coagulation system, and the kinin system, or kinin system, K-I-N-I-N. So some cellular components of inflammation are going to be your polymorphonuclear neutrophils, or PMNs, as they're called. They arrive at the sites in the tissue where they are needed, and then this process is going to involve two major stages: an intravascular phase and an extravascular phase. During the intravascular phase, leukocytes move to the sides of blood vessels and attach to the endothelial cells. During the extravascular phase, leukocytes, or white blood cells, right, travel outside of the blood vessels to the site of inflammation and kill the organisms. The cellular event sequence is margination, then activation, then adhesion, then transmigration, and then lastly, chemotaxis. Cellular products of inflammation are your cytokines, which affect the function of other cells. Your monocytes, monocytes release monokines, and then lymphocytes release lymphokines. And then you have also interleukins that attract white blood cells to the sites of injury and bacterial invasions. And then interferon. Interferon is a protein produced by cells when they are invaded by a virus. Lymphokines stimulate white blood cells, or leukocytes. Macrophage activating factor stimulates macrophages to help engulf and destroy foreign substances. Migration inhibitory factor helps white blood cells at the site of an infection or injury until they can perform their designated task. It helps keep the white blood cells at the site of an infection or injury until they can perform their designated task. Right? All right. Injury resolution and repair. So normal wound healing involves four steps. The repair of damaged tissue, the removal of inflammatory debris, the restoration of tissues to a normal state, and then the regeneration of cells, the healing process. Wounds heal by primary or secondary intention. Primary intention occurs in clean wounds with opposed margins. Secondary intention occurs in large gaping or infected wounds, which calls for a more pronounced and prolonged inflammatory phase. The factors that lead to dysfunctional wound healing, it could be local or it can be systemic. Some of the local factors are going to include infection, inadequate blood supply, and foreign bodies. Going to cause issues. Some systemic factors are going to include inadequate nutritional intake leading to insufficient levels of collagen. Anything that interferes with the epithelialization or wound contraction. Hematologic abnormalities as well are going to cause that. Diabetes, AIDS, and then use of corticosteroids are going to cause issues as well. The chronic inflammatory responses usually caused by an unsuccessful acute inflammatory response. Associated with an infiltrate like pus, containing monocytes and lymphocytes, and usually involve tissue destruction and repair. So there's your illustration for inflammatory response. Gaze on it in all its wonder. All right, so variances in immunity and inflammation. All right, hypersensitivity is any response of the body to any substance to which a patient has increased sensitivity. Allergy is a hypersensitivity reaction to the presence of an agent. Autoimmunity is the production of antibodies or T cells that work against the tissues of one's own body. Isoimmunity is the formation of T cells and antibodies directed against the antigens or another person's cells. And then types of hypersensitivity reactions are going to be your type 1 immediate hypersensitivity reactions. It occurs in response to a stimulus or degrees of severity, and then the degree of severity varies. Type 2 cytotoxic hypersensitivity, the cells are destroyed by complement fixation or other antibodies. And then you have type 3 tissue injury caused by immune complexes. So it may be systemic or localized. The systemic form is serum sickness, which results from a large single exposure to an antigen, or localized form is an Arthus reaction. It's called an Arthus reaction. And then you have type 4, which is going to be delayed. It's a cell-mediated response hypersensitivity. So there's two subtypes, delayed hypersensitivity and then cell-mediated cytotoxicity. So here is type 1. So the immune system targets different molecules depending on the type of hypersensitivity reaction. In allergic reactions, the target is an antigen or an allergen. In autoimmune reactions, the target is a person's own tissues. Some examples can be Graves' disease, type 1 diabetes mellitus, rheumatoid arthritis, myasthenia gravis, or SLE. Immune deficiencies are this. Immunodeficiency is the body's immune system is inadequate and resistance to infectious diseases is decreased. They can be congenital or acquired. Congenital immunodeficiencies are your parents have inherited defects that involve lymphoid stem cells. Okay. Acquired immunodeficiencies, nutritional deficiencies may depress bone marrow functions and diminish white blood cell development. It can be caused by trauma. Also, iatrogenic immunodeficiency is caused by medications or treatment. Iatrogenic. And then in any case, replacement therapy is available for immunodeficiencies. So there's some factors that can cause or contribute to disease. So controllable versus uncontrollable risk factors. Uncontrollable factors such as genetics and race influence the development of disease, right? Many other factors such as smoking, drinking alcohol, inadequate nutrition, lack of physical activity, and stress can be controlled. The risk of a particular disease often depends on the person's age, and we talked about that before, right? In some cases, sex is related to the risk of having a certain disease. So analysis of a disease risk involves the consideration of disease rates and disease rate factors. Casual factors, which are risk factors that directly cause a disease to develop. Non-casual factors, those are risks that are associated with a disease, but not a direct cause. All studies of a disease should consider the incidence, prevalence, mortality of the disease. And then risk factors are age. Risk factors are age and sex differences often interact. Risk factors, age, and sex differences often interact. Yeah. So there's some common familial diseases and associated risk factors. A true genetic risk is one that is passed through generations by inheritance of a gene. Diseases with familial tendencies seem to cluster in family groups despite the lack of evidence for heritable gene-associated abnormalities. Like when they talk about heart disease and things like that, get into high blood pressure and all that good stuff. Immunologic diseases are caused by hyperactivity or hypoactivity in the immune system. A person who has an allergic tendency is said to be atopic. If I'm not mistaken, sickle cell is going to be a gene associated. Yes. Usually in African-American males. So that's one that we talked about, sex-related also. Usually in African-American males. I just want to be sure. Really? Yeah. So it says both the mother and the father pass the defective form of the gene for a child to be affected. So both the mother and the father have to have it in order to pass it. If only one parent passes the sickle cell gene to a child, that child will have sickle cell trait. With one normal hemoglobin gene and one defective form of the gene, people with sickle cell trait make both normal hemoglobin and sickle cell hemoglobin. Their blood might contain some sickle cells, but they generally don't have the symptoms. They're carriers of the disease. However, it means that they can pass the gene to their children. So in order for a baby to be born with sickle cell anemia, both parents must carry a sickle cell gene. That's okay. That is perfectly okay. All right, cancer. So cancer describes the pathology associated with malignant growths in various anatomic areas. Prognosis often depends on the extent of its spread, the metastasis, right? Or metastasis, and the effectiveness of treatment. Breast cancer is the most common type of cancer occurring among women. And then colorectal cancer is the third most common type of cancer in men and women. So another common familial disease and associated risk factor is going to be diabetes mellitus. One of the most significant, diabetes mellitus is one of the most significant endocrine diseases. It's associated with partial insulin secretion or total lack of insulin secretion by the pancreas. Ketoacidosis prone or type 1 or insulin dependent diabetes is what is type 1. Type 2 is non-ketoacidosis prone or non-insulin dependent diabetes. Then you have hemolytic disorders. Hemolytic anemia is characterized by an increased destruction of red blood cells. This disorder has a number of causes, such as an Rh factor blood transfusion reaction, a disorder of the immune system, and exposure to bacterial toxins or chemicals such as benzene. Hemophilia is an inherited disorder characterized by excessive bleeding, right? One of the blood clotting proteins necessary for blood coagulation is absent. And that's what causes that. Hemochromatosis, is an inherited disease in which the body absorbs more iron than it needs. Families. See what families do to you. All right, so cardiovascular disorders. Cardiomyopathy is diseases of the myocardium, diseases of the heart muscles, right? Mitral valve prolapse, coronary heart disease, which is caused by impaired circulation to the heart. Hypertension, which is high blood pressure, and then also stroke. So this just shows a comparison of normal cardiac function with malfunction characteristics of the hypertrophic cardiomyopathy. A is a normal heart, illustrating unobstructed flow of blood from the left ventricle into aorta during ventricular systole. And then B, B is hypertrophic cardiomyopathy. It's illustrating the obstruction to outflow of blood from the left ventricle to the hypertrophied septum, which impinges on the anterior leaflet of the mitral valve. So here's some others. Renal disorders like gout. It's the abnormal accumulation of uric acid, and then also kidney stones. Look at that mess right there. Oh my goodness. It's over. It's about, that thing's about 7 centimeters. You imagine having to pass that? You couldn't. You wouldn't. So here's some others: gastrointestinal disorders like malabsorption disorders, lactose intolerance. I have lactose intolerance. It's terrible because I love milkshakes and ice cream. Ulcerative colitis, peptic ulcer disease, gallstones, obesity is also familial. So obesity is considered a body mass index greater than 30 kgs per m². And then morbid obesity is a BMI of 40 kgs per your mass or greater. And then overweight is a BMI 25 to 29 kg, 29.9 kgs. But it's caused mostly by genetic and behavioral or environmental factors. So behavioral meaning, when you get bored, you eat. When you're upset, you eat. When you're depressed, you eat. When you so on and so forth. And then if it runs in the family, it makes it that much harder to combat because you're more likely. Fighting against history. So neuromuscular disorders are going to involve, like for familial diseases, are like Huntington's disease, muscular dystrophy, multiple sclerosis, Alzheimer's disease, and then you have also psychiatric disorders. Some common psychiatric disorders are they have familial or a genetic component, such as like schizophrenia and bipolar disorder. So stress and disease. Stress includes a wide range of strong internal stimuli. Physiologic and physiological that can cause a physiologic response. So physiologic stress is a change that makes it necessary for the cells of the body to adapt. Some concepts related to physiologic stress include the stressor itself, its effect on the body, and the body's response to that stress. So general adaptation syndrome, it characterizes a 3-stage reaction to stressors, physical and emotional. You got stage 1, which is alarm. The body reacts to stress first by releasing catecholamines, like epinephrine or adrenaline, or norepinephrine, or noradrenaline, and dopamine. Stage 2, resistance and adaptation. The body adapts to stressors primarily by stimulating the adrenal gland to secrete glucocorticoids and mineralocorticoids. The anterior pituitary releases androcorticotropic hormone, or ACTH, and then endorphins are released as well in that resistance or adaptation phase. Stage 3, exhaustion, which is the adrenal glands become depleted, decreasing the blood glucose level and resulting in decreased stress tolerance, progressive mental and physical exhaustion, illness, and then collapse. Here's a fantastic illustration. I'm out of blueberries. Let's go. All right, so here's an illustration that shows how stress triggers secretion of adrenocorticotropic hormone. which results in cortisol secretion. And you can read about cortisols when we talk about weight loss and things like that. Or weight gain. So the effects of chronic stress are hypothalamic, pituitary, adrenal axis controls reactions to stress are going to be like continued stress leads to a loss of normal control mechanism of hypothalamic, pituitary, adrenal axis. The adrenals continue to produce cortisol, which exhausts the stress mechanism and leads to fatigue and depression, and it interferes with serotonin activity. A consistently high cortisol level suppresses the immune system. And coping mechanisms may play a role in physiologic response to stress. So effective coping mechanisms can help a patient improve his or her immune system response. Oh my goodness. It is the end. All right, so do we have any questions about any of that? Let me find our computer's lagging. All right, so tonight, or not tonight, but tonight opens up the Chapter 8 quiz. Hopefully it opens it up. I don't have any control over it at this point. I believe I got it opened up for that. And so take that test and then read Chapter 9, Lifespan and Development. And Wednesday we'll be talking about that. Also on Wednesday, we'll be completing the Module 1 exam, or it'll be opening up to complete that. And then I'll also put in there the Module 1 discussion from there, if I can get into it. So we will see. But for now, the Chapter 8 quiz is what we want to get done, right? And in order to have the Chapter 1 quiz, you need the code for today's lecture. Today, hold on, which is 19 July. The code is 8612. The code is 8612. Mod 1 study guide. I would, if I had control of my stuff. If I had control of it, I would have a Mod 1 study guide. Let me see what I can do today and tomorrow about that particular situation. And then we'll see from there if I can give a good study guide for it. I tell you what though, knowing your past exams may help you out tremendously. Just saying. Past exams may help you out tremendously. the code up. All right. Does anybody have anything else they'd like to discuss? Okay. So what I'm going to do is I'm going to go ahead and stop recording.